လူပုံတွေအများကြီးပဲတွေ့နေတယ်မလားလူတယောက်တော့ထွက်လာပြီ recording ဆိုပြီးတော့သိလားကလိုင်းတကောင်ပုံတော့ထွက်လာပြီလို့ကြည့်လိုက်အောင်နင်နောက်ဖုန်းတစ်လုံးရှိလား
Hello.
Hello ဒါ on နေပြီ Hello ဒါ
Chumpon. Good evening.
Implant IBS ကလိုင်းတယောက်ထွက်လာရမလားနေကြတော့ connected to audio ဆိုနေလားမသိဘူးသိလားညနေတော့မတွေ့ဘူးမလားညနေတော့အတွေ့မခံဘူးကြီးတော့မချိုးရသေးဘူးလား
comme Word ou Excel, en effet, vous retrouvez les mêmes fonctions.
Are you in Hawaii?
Yeah, and Pattaya.
Nice.
I know. Can you hear me clearly? I know.
Yes, I do hear you.
Okay.
I hear you well.
يعني اي زين
ما اقدر البس يعني شلون يصير
لبسيه بس نسيت اشوف هاي اخذت 24 ساعه اخذتها بس الحشوه يلا زينة اللي فيها على الحشوه ولازم متى تكبر الحشوه خذوها انت تجين ان شاء الله على مود الحشوه فيها بس يابسه او تبي تشيل
시작하려고 어쨌든 현대 들어가려고 계속 한 겁니다.
셀프도 들어가면 되더라. 조금 몰랐어.
뭐 하는 거야, 맨날. 뭐 하는 생겨가지고. 옷을 그렇게 입고 가야 되는데? 그걸 알고 나 몰랐거든. 근데 거기 있는 애들은
소리 껐는데도
걔 맨날 이거 끼고 있는 거 알지? 걔 맨날 이거 끼고 있는데 혼자만 해도 돼도? 들을까? 이 말이 보여주는 거 아니야?
어떻게 해야 되지? 잠깐만. 쉬어. 회사 이거지. 짜증나 죽겠네.
주말에 회사에서 이러고 와?
무슨 야 말도 하지 마. 짜증나.
아유.
You are using your device on. Hindi ako marinig.
Good evening, ladies and gentlemen. My name is Ainur, and I'll guide you today throughout the seminar. As of start, I would like to thank IBS Implant Company for giving us opportunity to gather all together and observe minimally invasive implant treatment concept. Company was established back in 2008 and had its priority to patient treatment so that every single patient left satisfied with the quality and results of it. As a result of study and research, our company established academy where every single dentist can learn details and techniques of implant treatment. The Academy of Minimally Invasive Implantology teaches theoretical as well as practical hands-on trainings on the IBS Magic surgical system and the Magic Core implant, which is specially designed to be optimal to minimally invasive treatments. We aim to create a clinician community who can perform treatment regardless of poor bone condition or narrow bone width. We're sure that they can be competitive in their practice as well as provide their community with the most modern and advanced dental implant treatment. We hold regular courses 4 times a month to deliver our knowledge. We continue to overbook seats at our courses, making us one of the most desirable training programs in the industry. Throughout regular symposiums and seminars, we introduce our Magic Guide system, which makes for more exact radiographic diagnosis and drilling, resulting in guided surgery method, which is even more accurate and easy to perform. And now, let me show you the introduction of the company.
Hello, Mr. Michael.
Conventional implant surgery and started an implant system research for minimal invasive surgery. After endless research, he developed a magic surgical system.
Hello, con Thủy. Anh là cái người của mẹ ra đây.
Hả? Ôi,
Anh là cái của mẹ.
Would you be so kind to turn off your mics?
Implant surgery has shown marvelous advances in progress in medical technology. However, complicated techniques and damage inflicted upon patients did not show much improvement. Among global implant companies, there is a global scale company setting a new standard to the market.
Vâng, sửa đổi này được implant đâu.
By hosting annual World Symposium, we have agreed upon how you agree that technologies of various mediums best efforts for technology. Unlike the conventional implant system, anatomical structure and with surgery, it has overcome the comparison. State-of-the-art manufacturing systems for collaborative research with clinical doctors and safety of patients, realizing efficient production and global level quality with precise quality inspection. Especially Anterior, a fixture for core crown, is IBS's own product that is optimal for flapless surgery and won planned 5 Korea Patent Awards for its implant design of world's first minimal invasive product. IBS International Clinical Education Center provides theoretical education on flapless surgery. Flapless surgery that can only be seen in center. Even doctors unfamiliar to flapless surgery can easily perform the surgery after sessions and are making good outcomes as of now. IBS technological innovation and is continuously.
Hello.
And now,
Assalamu alaikum.
let me
Assalamu
introduce our
alaikum.
first speaker for today with his lecture on basic concepts of minimally invasive implant treatment. Dr. Chamachot Chumpon, Doctor of Dental Surgery, graduated from Faculty of Dentistry in Mahidol University. Postgraduated in Oral Surgery in Chumpon University. He is a senior consultant in Princess Mother Nation Institute, Secretary and Committee at Policy Development Committee of Drug Treatment Accreditation. He is also a certified Academy of Minimally Invasive Implant Treatment Advisor. Dr. Chumpon?
Okay. Maybe from Asia, from Europe, from America, from anyone who from all over the world. Okay. Today, I try to share my experience and share my knowledge about using Magic Core. Okay. Okay. Do you see my presentation now?
Yes, we do.
Yes. Okay. Thank you, Hanua. Okay. Today, I'm gonna talking about the basic concept of Magic Core and case study of mine that can help you to understand more about minimal invasive treatment. Okay? And after that, Dr. Endo will talk about the special technique, BEB and CMC technique. Okay. First of all, I have to thank you to IBS company that invite me to join this Dr. Wang seminar in end of January this year. And thank God that at that time the COVID-19 don't be pandemic like this. Maybe about 2 weeks before that happened in Asia and all over the world. Okay, so I can come back from Korea to Bangkok. Okay, and from that time I still studying about this technique and this system about the minimal invasive implant treatment. And when we talk about minimal invasive implant treatment, we concern about 4 things. First, the technique should minimal the damage of soft tissue. The second, minimal damage to the hard tissue in the bone. And usage of a material will less than the others, such as use no bone graft, less bone graft as we can, no GBR, and minimize the number of surgery. Almost the surgery done with this system, only 1 surgery. Okay. And about the Magic Core is one of the best minimal invasive implant treatment. I will talk about the 3 parts that very important about Magic Core system that be different from conventional implant. 3 parts that are different is, first part is the magic cuff. The magic cuff is very, very helpful and familiar to the tissue, surrounding tissue of the implant. The magic filtrate can get the stability by do no harm to bone, don't destroy the bone anymore. And the magic pores can withstand the stress from chewing in any direction. Okay, when you go back to the conventional bone level implant, I'm using bone level implant for 20 years, okay? From my experience, when we use bone level implant, many cases you have to add the bone graft over there to make the bone enough for the prosthetic design of the implant. Okay, but however, when the time passed, we found that many cases bone resorption and gingivialization occur. Okay, this little bit short video can explain what happened. Okay, I will stop for a while for speaking. Okay, in the conventional implant, bone level implant, that's not a tissue level. When you want to do the prosthetic procedure, you have to unscrew the healing abutment. And at that time, you open the window for the bacteria to get inside, and you do damage to the soft tissue around here. When in the tissue level, the bone and the soft tissue still there, no border, no interference occur with the tissue level like this. And then when you're going to take an impression, you have to put on the impression coping abutment, and something occur. The sound cuts occur here. The sound cuts occur here, but in the tissue level, no sound cut occur. And when you put back the healing abutment, the sound cut still there and deepen more. Okay, what happened next? The tissue or the body want to regain the biologic width. You can see in the tissue level on the right side, the connective tissue is around 1 millimeter. But on the left side, connective tissue is still less, okay? So the body want to regain biologic width, and what happened next? The bone resorption occur in many cases to regain the biologic width like this. So when you put on the prosthetic crown, the cell cut will be here and make not easily to clean. While in the magic core, the healthy the gingiva can bring the gingiva can go over the crown and cell cut is there. And we call this situation is on growth. Can happen in magic core system. And again, I describe to the diagram again. When we use a bone level, at first, the biologic width is very good, but after you destroy the junction, you bother to the gingiva around here, you make the sound cut occur here, and the sound cut still there in the final prosthesis. So in the long term, bone resorption and gingival can occur. Okay, compare with the magic core system, the healthy periodontal teenagers, but the other that I used to use the bone level implant, I found that the gingiva is like a 40 years old people. Okay, it's an example when we use the tissue level, such as magic core system. You can see in the picture, the junctional epithelium attached very firmly here to the cuff. We call this part is a cuff of the implant, a tissue cuff. The junctional epithelium attached here. Here is the junctional epithelium. No sound cut, and the first time we put the final prosthesis. But when the time passes, 1 or 2 or 3 weeks, from the healthy tissue, on growth occur. You can see the gingiva up to there to make a sound cut in this area. The sound cut is on the level of the crown. Compared to the bone level implant, the sound cut deeper, near to the crest of the bone. In some cases, when we do the magic core, we found that at first the gingiva in here have no keratinized tissue, but when the time passed by 2-3 weeks or 1 month, it's changed to be the junctional, to be the keratinized tissue that more healthier. And we talk about something. When you do some of the bone level implant, the gap may be here. And when the force from the chewing occur, the micro gap can occur here. Even when you change to switching platform, it can prevent that problem but still occur, especially when the screw is loosening, that I found many cases. To solve this problem, okay, the bone level implant, when get the force from the micro gap and micro movement occur, but for magic core, because of the strong body here, movement not occur, so the bone loss can be prevented. Okay, this is very important and benefits of the magic cuff. In this system, magic cuff that can do many things because magic core have many length of magic cuff to choose, 2, 3, 4, or 5 millimeter up to the height of the gingiva that in the patient we use. Okay. Okay, let me erase some. Okay. Now I'm gonna to talk about next. Okay, sorry, what happened to my slide? Oh, what happened to my slide number 4? Okay, next I'm going to talk about magic fin thread. It's a very important part of the magic core. You can see when we use a conventional implant, usually the thread was designed to be the triangular shape, and when we put in the implant into the bone, to make stability, we have to push on the bone, and by the shape of triangular, the destruction or destroy or make the bone broken occur here. So that means when healing process continue, more time to healing in that area. Why in the magic core we use magic fin thread? Before we put the implant inside, we use a specialized equipment to cut the bone. Don't push the bone, don't destroy the bone, don't break the bone, just cut the bone to make a thread like a screw thread inside the bone and passively, softly screw in the implant like this. Okay, so when we use the triangular shape of the bone and have a bone destruction here, so and when you do the implantation, you have to open the flap, soothing damage to the bone, and the consequence is the bone can be resolved easily. So that means when you use the triangular shape, you have to have the bone around 1 millimeter needed to prevent the bone resorption. Okay, or let's say that when you do the implant in a narrow bone, you need 2 millimeter greater than the diameter of the fixture, such as when you have to use the bone 4 millimeter, you have to do in the bone that around 6 millimeter of the bone width of the crystal to use for diameter of fixture. While in the magic core, as I said, we use this drill, we call magic tap drill, to make to cut the bone inside the crystal. This is a magic tap drill, and after that we place the implant by screw in softly. Don't push the bone and don't destroy the interthread bone anymore. And stability occurs not by 40 Newton or 35 Newton, no need for that Newton, but we use morphologic contact concept. If you have play Lego, it's like a Lego that lock together, but no place, no push, no force together. And you can see this cross section of a magic fin thread. You can see this is a bone enough to prevent resorption. And for the magic fin thread, we need only thin bone around here, can prevent resorption. We need only 0.25 millimeter over the thread, because in the thread bone, we have much more bone to make a stability occur. And we use this minimal invasive technique. We don't open the flap here, so we keep the blood supply to the bone. Let's say that bone width is only 0.5 millimeter greater than the magic core. Let's say that if you found the bone that only 6 millimeter, you can put the implant diameter 5.5 in that area without problem. And from the magic core design of the fin thread, you can see in the normal or conventional that the thread like this, when you shooting or make the force to the implant, the force distribution of the thread mostly on the upper part of the implant. While with the design of a magic core, the thread can distribution along the surface of the implant. That means functional surface is more, so the success rate may be higher. Okay, conclusion that with the magic core, you can use the big diameter in the narrow crestal bone, just only 0.225 millimeter over the thread, or let's say 0.5 millimeter bigger than the diameter of the fixture. Okay, and that is the very best thing that I love the fin thread like this. And next, I'm gonna talking about magic pose. Okay, you can see the magic pose act like a part of the abutment. The magic pose only 2 millimeter, and make the strong connection with the body of the implant and with the crown. Okay, let's see. Because of when you use the conventional bone level implant, you have to place the implant in the angulation that center of the prosthetic part opposite to the upper tooth to make the force go past the center of the implant. But if you try to avoid bone grafting by put the implant along with the crestal bone, along with the angulation of the bone, what happened? The force from the opposite tooth will pass here and make the broken on the fixture like this. Okay. So you have to put place the implant in the direction of a prosthetic center concept. cannot do the bone center concept in the conventional. But for the magical concept, we want to do minimal invasively. We don't want to use bone grafting or GBR. Okay, so we try to use bone morphologic bone concept, get along with the bone. You can see magic core design, a magic crown. You can see that. That connection with the implant as one body, so it's very strong. So when we use the implant, the magic core get along with bone center like this. So the force from the opposite tooth will go like this, but no problem because we have both external and internal connection. And this is a one body implant system, so can withstand or can get the straight by without no problem anymore. No need for GBR, for no need for bone grafting in a situation like this. And this is a real case of the magic core. You can see the angulation of implant is outside the reach because when we do the placement, we have to get along with the bone center implant. And the prosthetic part can be here. You can see a little pin inside. Connection completely. No problem about the prosthesis. And for the magic crown, we have both cemented type of magic crown. If you like to cement type, or you can use screw retain type up to your favorite, up to your passion. You can do in many ways. Okay, and that is the basic concept of the implant magic core. Magic cuff that very good to soft tissue, prevent downgrowth of the sound cut until reach the implant thread, prevent bone resorption. Magic fin thread that can put in the bone without destroy the surrounding bone, make the healing faster. Magic pose make you can do the bone center implant and no problem about the prosthetic angulation. Okay, from that thing that I'm talking, I'm going to tell you about the surgical technique, okay, that we use minimal invasive concept. I let you all learning from my case study, okay, learning by doing, okay. Okay, you can see we have to make a path of the screw inside the bone and simultaneously, softly screw in the implant without stress. Don't need 40 Newton, don't need 35 Newton because it's a morphologic stability. The concept of do this is magic fitting drill and magic fit implantation, okay? Okay, I have to tell you frankly, after I finish the program, training program and hand-on program on end of January this year, about not more than 10 years, not more than 10 days after that, I come back to Thailand and I can find some case that's suitable for magic core to start the first magic core system of mine and the first magic core system in Thailand. is the patient zero of mine, okay? Because it's very easy. I think it's very easy. Just one course, I can do that. Okay, you can see here, number 46, okay? I'm lucky that the bone is very good. Bone is very good, okay? With a big bone, okay? But even in the big bone, the concept of placing or surgical technique of magic core, the gingiva is very important. You have to determine the location by looking at the quality of gingival surface, okay? Usually we use bone level or bone center concept. So the first, you have to put in the middle of the crestal bone, but you have to check that the gingiva aura that is good or not. What is the gingiva that good? The good gingiva is the gingiva that does not move. So if you choose to implantation here, you have to use the gingival probe to check this area about 2 or 2.5 millimeter from the position you intend to place the implant, and use your mirror to tracking the buccal mucosa. If the tissue in here does not move, that means good to do in this position. But if this area is moved, get along with your mouth mirror, you have to change the location that proper than that, okay? But in my first case, you can see I choose to do in this area because the bone is big enough, so I can do both bone center and prosthetic center at the same time. I choose position A, but I have to check first that the gingiva around here is good or not. So I have to check the gingiva at point B is moved or not. And then found that the gingiva at point B and the buccal side of the point A or mid crestal is not moved. Okay, that means it's a very good position. So the point A is a very best position for put the implant in this case. Before I drill the first drill of the implant set, I have to check the bone density first by use a magic split that inside the instrument kit. You can check the bone quality by push by your hand. If the magic split can cut and can go in the bone until reach the blue area here, that means the bone is very soft, like a D4 bone. But if not, maybe D1, D2, or D3. In the D4 bone, we cannot use the drill to drill the osteotomy because it's too aggressive. If the bone is D4, you have to use the other technique, such as BEB or CMC technique that Dr. Ando will talking about this after me. But in this case, it's a D2 bone, so I can drill with the magic fit drill. Okay. Now, we have to palpation to know exactly about the bone is because we don't open the flap, so we cannot see inside what is the bone shape is. So we have to palpation to estimate the bone inside, okay? But for this case, the bone is very big, so I can use prosthetic center, okay? But in some case, if the bone is narrow, you have to do bone center concept. Okay, at the point A, okay? I use the first drill, we call a pin drill, and we use pin drill at the mid crestal at the point A. You have to remember that we use this drill only to pass the cortical bone only 3 millimeter or 4 millimeter. That's enough. not more than that, okay? Because we want to make a drill in the direct path in the proper angulation. And after that, we will use the guide pin. You can see we use a drilling pin here about 3 or 4 millimeter, and we put the guide pin inside the hole like this, inside the hole like this. And if you have CBCT, you can check the angulation of the guide pin is correct or not, because after that you will use the main drilling equipment to drill along this part. But don't worry about CBCT, because in Thailand also not every clinic have a CBCT. I think only 5 to 10% of clinic in Thailand that have CBCT. And the same as my first case, I don't use CBCT too. I just use only the plain film to check the angulation of the implant. You can see here. Yeah, from the first guide pin that I put in the bone, I found that, okay, this angulation, I like it. I want to drill further by use this angulation. So I go on. You can see the guide pin inside here. And with this guide pin, we use magic drill. Magic drill have a hole at the tip of the magic drill that will cover the guide pin. Let the guide pin bring you drill in the correct path that you plan. Okay. But before you drill with the magic drill, you have to choose the cuff, because I told you we have many sizes of cuff. This is the cuff area. We have to choose the cuff up to the height of the gingiva. If the gingiva height is about 3, we have to choose the cuff height 3. And the gingiva is 2, you have to choose the cuff height 2, the same. Okay. So to check the height of the gingiva, we use the gingival probe here to push 4 points, 1, 2, 3, 4 around the guide pin, to check the height of the gingiva first before we choose selection of the implant. And for this case, I found that on the buccal is 2 millimeter, mesial is 2, distal is 3, and lingual is 2. Usually, I like to use the buccal because from the concept of magical, we have to put the cuff part here at the same level of the gingiva, in the posterior part, this level of the cuff, which I call is margin of the cuff, will the same level of the gingiva. In this case, 2 millimeter, that means I have to choose 2 millimeter of the cuff part. But if you do in the aesthetic area, in the maybe on the anterior tooth, the gingiva much higher than the margin of the cuff, about 1 millimeter here, and left the pores 1 millimeter out of the gingiva. Okay, this is a concept for doing in the aesthetic area. But for this tooth, it's in the posterior tooth, so I just measure the height of the gingiva and choose cuff of the implant only 2 millimeter height of the cuff. It's okay. Okay, this is a slide that I told you about in the aesthetic zone. We have to put the implant that the cuff 1 millimeter under the gingiva level and left the pore 1 millimeter over the gingiva. But in the posterior, the margin of the gingiva, the margin of the cuff must be equal to the level of the gingiva. For the length of the implant is the same as you use conventional bone level up to the bone for the fixture for this level. In this case, I choose 2 millimeter here, and I choose 2 millimeter here for the gingival height, and I choose the implant 9 millimeter from the bone. So 2 plus 9 equal 11. That means when you make a drill, you have to drill depth 11 millimeter from the gingival level. Okay. Okay, let's see the real thing. Okay, it is my case. Okay, gingival thickness is 2. The cuff should be 2, as I said. And the fixture from the bone, I choose 9. And the diameter is 5.0. So I have to drill 9 plus 2 equal 11 millimeter. And measurement start from the gingival margin at the block hole margin here. Okay. When we use the magic drill, we use the drill cover the pin that we make sure is the correct path already until reach the desired length. In this case, I decide to 11. Okay, after that, some of the bone may be left inside. So you have to use the spoon excavator to remove some of the bone that inside the hole. And to check, or maybe you have to use we call depth drill to check the depth is 11 millimeter or not. Sometimes when we use depth drill and we found that not enough, you want to drill more, you can use the depth drill to drill more until you happy about that level. Okay. Okay, as I said, I use my magic drill cover the guide pin and drill. At first, we have to drill the guide pin out first. In this step, I drill only 3 to 4 millimeter at this step to just remove the guide pin. Okay. And after that, you can see a hole, but inside the hole only 4 millimeter. Not enough because I decided to drill 11. That's right. So I check again with the instrument inside and the instrument kit. So this tab is 11 millimeter. Okay, and after that, I'm going to drilling until reach 11 millimeter from the gingival height. And then I use spoon excavator to remove some of bone left inside, and I use depth drill to drill again to make sure the 11 millimeter from the gingival level is okay properly. Okay, after that you got the hole. That inside the hole deep is 11 millimeter. Is ready for place the implant. Okay. Before to place the implant, you know, we want to do no harm to the bone anymore. We just cut the bone out. And when we put the implant inside, we don't want to place the bone or broken the bone, broken the interthread bone. So before to put the implant inside, we use the magic tap drill to cut and make a path for the thread inside the bone. When we use this already, first we use with the machine, and after that we use by the hand instrument. Okay, but we don't need to do all of the length. We have to avoid 3 millimeter at the bottom, because maybe you damage 2 more. Okay. This is a magic pin. Okay, why I have to use it? This magic pin used for guide your tap drill. Okay, guide here. Inside have a hole and prevent 3 millimeter from the bottom that don't want to go more than that. So we use the magic pin to guide the direction to make a thread inside the bone, inside the osteotomy hole. Okay. Okay. We put the guide pin or magic pin here, and we use a magic trap drill until reach 3 millimeter from the bottom of the osteotomy hole. And after that, in the bone have a path that make ready for insertion the implant. We call magic fit implantation. So slowly and softly place the implant inside the hole, okay, until the margin of the cuff equal to the margin of the gingiva, like this, and cover it with cover screw. That's finished. That's finished. You can see no flap operation. The patient said, okay, no pain, no pain, because an anesthesia is still there. But after 3 or 4 hours, when anesthesia gone, not much pain like the conventional flap operation. Okay, this is the bone and the implant inside here. On 6 February, about that I said to you about not more than 10 years, and not less than 10 days, less than 10 days after I graduated from the program. And this is the 3 months later. We're gonna do the prosthetic procedure. In fact, I plan to do earlier than this, but because of COVID-19, so I have to postpone my patient for a while until the situation is better today. So I bring my patient back to do the prosthetic part, take an impression. Okay, use the impression coping here, and you can see impression coping don't bother the gingiva anymore, because the gingiva is here. No harm, no interfere when you take an impression. Okay, and after that, I use short abutment connect here to make it longer enough to make a crown. And I put the crown. I use the cemented crown for final restoration with a screw hole that we call hollow crown. Cement time, but I want to leave the hole here to, if something happen in the future, I can screw out the implant, screw out the prosthetic part. Okay, and that's the very beautiful case one that I have done. This picture I just take yesterday. Okay, just yesterday, and you can see the gum, the tissue is very healthy. And if 1 or 2 months later, if I have an occasional, I have come back to show you what happened in the next 3 months. Okay, the second case, I sent my patient to do CBCT in the other clinic to evaluate about the bone. But in my clinic that I've done this case have no CBCT. So I just planning by CBCT, and I found that, okay, the bone is okay. The bone height is okay. So, and that day I used only plain film. You can see the first guide pin that I done is not good. The position gonna down to the root. So I can change the direction and change the position to avoid the root of the next tooth, and this guide pin can guide me to put another one correctly. Okay, also. And after that, you can see in the mouth, and I use these two guide pin to guide my insertion, to guide my tap drill, and guide my drilling machine to drill in the correct path. And after that, I can put the implant in the parallel path like this. So I like guide pin system like this very much. Okay, and that's all that I learned from the Magical system. In fact, I have done about 5 cases of a Magical for now, and the other case I have used only plain film, no CBCT at all, but everything with okay, everything is very beautiful, okay, and maybe next two months when I finish the final restoration, I will share with all of you about the result of the Magical that I used in Thailand. Okay, conclusion that for this type of implant, this tissue level implant that have a design and unique tissue part that very friendly to the gingival tissue, and have a thread that have a very unique thin thread that can make stability in the first time you put the implant inside the bone, and shorter of the healing process, and you can do early loading, or maybe in some case you can do immediate loading for the implant like this. Okay, and long-term success is very high. So thank you all that listen to my presentation. If you have questions, feel free to ask me. Okay, I will answer you all. Okay,
yes,
thank
Dr.
you.
Chumpon. Thank you very much for your presentation. Actually, we do have few questions while your presentation was. Give me a second. So here they are. The first one, if the implant is placed not aligned with occlusion of the opposite teeth, the antagonist tooth, how can stability be achieved with Magic Core? Can it be achieved?
Okay, because when you put the implant aligned with the bone, the crestal bone, okay? So the bone will protect the implant very good. But the stability come from the morphologic inside. In that case, maybe early loading or immediate loading can be wait. But after 3 months or 4 months after the bone healing completely, the bone can withstand the force, no problem, because the bone healing completely. The more we concern is the prosthetic part, that if the prosthetic part not strong enough, it will broken the fixture. But you can see, as I told you, the design of the prosthetic part of the Magical is very strong because have both internal and external connection on the pores, and the abutment and the implant connect in one body, have no connection at all, so it can withstand the force in the long term.
Thank you. And the second question was, what will be the optimum rotation per minute or torque for placing guide pin?
Okay, about 1,500 RPM until 2,000. Okay.
Until 2,000.
Yeah.
Actually, there are a few more questions. I hope we have like 5 minutes to answer them. Give me a second, I'll find it. Without CBCT, how do you determine the buccal-lingual width of the bone and the angulation of the implant?
Okay. Without the CBCT, first use your finger, okay, first finger first. You can filling the shape of the bone. The second, I use needle. The need a little bit needle because you injection the patient already, so no pain. So you should needle put in the gum in the lingual side to measure the thickness of the gum on the lingual side, and use another needle put in the buccal side to measure the gum, the length, the height of the gum. So if all of the leash from you see in the normal tissue about, let's say, 8 millimeter, okay, from the top view to the lower crestal leash, okay, and you put the needle here or the gingival probe here, 2 millimeter in the lingual side, 2 millimeter in the buccal side. That means the bone fall, okay.
Yes.
So I use palpation and needle technique to predict the bone quality and the bone width, and which side of implant I have to choose. Okay.
Okay. Dr. Shyam from Nepal, he is saying like, thank you for the wonderful presentation. Can we use this implant system for immediate loading?
Okay, for the D1, I think for the D1 bone, if you can find that the bone is very good, and moreover, the technique that you use, if you sure that you don't break the interthread bone anymore, don't break the interthread bone anymore, you can make an early loading. But usually, in my, because I just do only 5 cases, so maybe something can happen to the interthread bone a little bit. So I avoid to do the immediate loading in that time. Okay, maybe wait a little bit, maybe good. Even everybody that start to do the magic core, the first to the, I think the number 1 to number 10 implant should be avoid to make a immediate loading. Until you have skill and more experience, you can do immediate loading with the bone quality very good in some cases.
Another nice question just came out. When you place an implant in bone-driven manner, place more than 30 degrees, for example, place more than 30 degrees from the direction of occlusional force. What will happen at the crestal bone? Will it receive a damage? Will there be a bone resorption? Will it cause any complications in the future?
Okay. I say the fact that I never been find that situation before, but from the study, we found that even about 35 degree because of the fin thread and because of the design of the implant. I think about 5 years, I don't remember it. I read that about 5 years can functionally function without any bone loss. Okay.
Thank you very much. There are lots of questions, Dr. Chumpon. I think we're running out of time to answer them all. I'll make sure to separately deliver all the questions to you. So hopefully you'll answer them, and we will post those questions in question and answer session in the results after the presentation.
Okay, thank you all, and nice to meet you all. And maybe in the future we can meet you all again and share about everything about the knowledge of implant in the future. Okay.
Hope to see you soon, Mr. Chumpon.
Okay, say goodbye in Thai. สวัสดีครับ สวัสดีครับ in Thai.
Thank you. Have a nice evening. So, we just, give me a second. We just finished the session from Dr. Chamachot Chumpon, and now we're going to listen for the more detailed techniques, the surgical techniques from Dr. Thanh An from Vietnam. Here's his profile. He's Doctor of Dental Surgery, University of Medicine and Pharmacy, Ho Chi Minh City, Vietnam. He had a master's degree in China Medical University, Taichung in Taiwan. He is a winner of Implant Research Award, APAD 2019. Also, he is a winner of Speaker Award in Sagaden Dental Implant Group. And he is also our AMI Clinical Advisor for Vietnam. Dr. Ando, give me a second.
Hello, Harry. Can you hear me?
Yes, we can hear you.
Okay. This way, a second, I will share my screen now. Okay. Can you see my screen?
Yes, we can see your screen.
Okay, good evening, everybody. It's my honor to be here and present with you some of my experience regarding to the bone expansion and sinus lifting using the technique invented by Dr. Wang. He's a president of IBS company. The term is a BEB and CMC technique. So these two techniques is specialized for minimally invasive implant treatment. So first of all, I want to introduce a little bit about myself. I graduated as a DDS in 2013, and during the next 5 years, I working with some renowned implantologists in Vietnam and also from Korea. Some of the professors from Yonsei University came to Vietnam and we work with them. And to 2019, I got the master degree in prosthodontics and also the residency in China Medical University. It's the top 100 medical university in the world. And I also work as a researcher at oral biological lab in Taiwan. And during the last few years, I published some publication, some research on the international journal, like clinical implant dentistry related research. So that's all about my profile. So the content today, I want to introduce with you some of the basic principle of the BAB and CMC. And what is the BAB and CMC? What is the principle behind those kind of technique? And how can we execute this kind of technique? So first of all, let's talk about the BAB. So before we start the principle of BAB, I want to present to you one of the clinical case where I have patients. So one of the patient presented to me that he had a problem with the anterior lower here. So the chronic periodontitis. The tooth is the whole teeth is mobility, and the patient really want to only want to do the rehabilitation for those 4 teeth here, but I have a problem with the patient that the patient did the implant treatment in the upper more than 4 years, and he suffered a very big complication. It's a big swelling and edema. So he doesn't want any treatment that prolong the time during the surgery process. he want very short treatment, time when we do the implant treatment. So we have to decide which technique we could use for him without a very big operation, without manipulating the flap to elevate the flap and do the major bone wrap in this area. So when we take the cone beam CT, at the surgery area we want to place implant, so we decide to place two implant and make a bridge for this prosthesis. So when we checking on the X-ray, the remaining bridge, which is only around 4 millimeter. So because we cannot do the major bone wrap, we cannot create the flap to elevate the flap, because when we elevate the flap, the occurrence of the non-stop bleeding is very severe for this patient. So we have to find a way more easier, more simple, more faster for this patient. So there was a technique in the literature named ridge widening technique, used for these kind of clinical cases. So the ridge widening technique is only used when the remaining ridge width is ranged from 3 to 6 millimeter. Under 3 millimeter, we cannot do this kind of technique, and more than 6 millimeter, so we don't need to do anything. So at this point of view, the ridge widening technique is a borderline between the ridge augmentation, or we could know the name is the GBR, guide bone regeneration technique. Like we use the bone particle or bone block to increase the ridge, the ridge width. In the literature, when they reported the success rate of the ridge widening, we can observe that it's very high success rate, more than 90% of success rate. So this technique is very predictable. And the ridge widening technique were introduced by Dr. Hugh Tatum since 1986. So Dr. Hugh Tatum is a very famous implantologist in the world. He was the man who invented the sinus lifting using in implant dentistry. There was a few classification. There was 3 kind of classification regarding to this technique. It's a ridge expansion, ridge splitting, and some kind of modified technique. It means combination of 2 ridge expansion and ridge splitting. So let's look at the history of ridge widening technique. So despite the first introduction by Dr. Hugh Tatum, the first paper reported regarding to this kind of technique were found in 1992 by Dr. Simeon. So he used the technique named is ridge splitting by using various kind of bone malleting and bone chisel to split the angular bone into the 2 plates, and then place the implant between the 2 splitted plate. Okay. And in 1994, Dr. Summer, this dentist is very renowned dentist also, because he invented the tool name is Osteo. Is used a lot of in the sinus lifting technique for the indirect sinus lifting technique. So he also used the tool invented by him to radially expand the cancellous bone without create a splitting of the ridge. So this technique is different with ridge splitting. Osteotomy expansion is rely on the cancellous bone expansion, but the ridge splitting is rely on the dividing of the cortical bone. So these 2 techniques is totally different in principle. So since 2000, there were a lot of techniques that were introduced using the combination of the 2 techniques. Like sorry, like they're using the piezo or cutting device to divide the ridge into the two parts, and then use some kind of the tune kit to condense the cancellous bonds. And it's very famous technique from Dr. Kuwes. Name is Osteo Densification. It's using the denser burr. So the principle is similar with the osteotomy expansion invented by Dr. Schumer. But instead of using the osteotome and malleting, the Kuwes is using the burr, is named a denser burr, is invented by him. So when we look at the literature, more than 60% of the case of the ridge widening technique case is using the osteotome concept. So what does it mean? So the reason why is more than the major case using osteotome concept, because this technique is very easy to manipulate, and the surgical field is smaller. So, and the osteotome can use for individual implant site, like ridge splitting. We cannot do for only one missing tooth, but osteotome can do that. So how can we combine those two techniques into the one technique that can use for every cases? So and a very important complication when we're using the ridge splitting technique is the bone fracture. The buccal bone fracture is the main complication when we're using the ridge splitting technique. So when we look at the principle of the ridge splitting technique, so the principle is they want to divide the ridge into the two parts, is we call ring stick fracture, and we do the lateral position of the buccal bone plate. It means the buccal replacement of the buccal bone plate here. So the main requirement to conduct this kind of technique is they require at least 1.5 millimeter bone plate for each side. It means the minimum thickness, the minimum width of the ridge is 3 millimeter. So when we split the ridge into the two parts, each part is have both cortical and cancellous bone. So the implant will be will be in place without creating the major bone resorption in the buccal plate. So it's very critical point is the remaining ridge width have to be more than 3 millimeter when we're using this kind of technique. So anyway, like I proposed, proposed before, the complication of the buccal bone plate fracture is always happen in when we do this kind of technique. So this is one of my case when I do ridge splitting technique in the upper jaw. So you can observe that the lingual plate is fractured here. So the reason why we have those kind of complications, why we have the fracture of the bone plate. So when we look at the way we conduct the ridge splitting, is we create the osteotomy line in the middle of the crest, and then use the compression, use the tool to wiggle between the two plates and create the compression to expand the two plates far apart from each other. So these two plates is connected at the two junction. So when the compression force is higher, the cortical bone plate is very rigid, but very easy to get fracture, right? So when the force is not well manipulated, the bond plate could be broken. So the reason is because the junction, the connection junction between the two plates, we create the whole force into only 2 points. That's the reason of the complication. So Dr. Wang, he invented a very brilliant method named is BAB. So instead of we created only one cutting line, he divided the side into the multiple cutting line. So when we creating the compression, when we wiggle the tune inside the implant side, so the compression force will be divided into the multiple junction between the bond plate. So this is the chain of the plate broken is reduced significantly. So this is a very brilliant method from Dr. Wang. So this method is name is BEB, as known as bond expansion with the cortical bond bending. Okay. Furthermore, when we look at the tune he used for this kind of technique, so we can observe that the tip of the tune is a very sharp tip, and beside that there were different sharp edge around the tune. So when we use the force to advance deeper into the bond, the force requirement is lesser than when we use the osteotome or the teasel. The teasel is only have a 2 plate, right? But the osteotome is like a conical shaft without any sharp tip. So when we use the osteotome, the force required for the advancing the tune is much more higher when we use the magic expander from Dr. Wang surgical kit. So when we use the lesser force, the trauma created to the patient is less than the other technique. So this picture is the surgical side when apply the magic expander inside to expand the bond out of the implant placement side here. Let's look at the basic protocol of the BAB technique. The first of all is we try to mark the implant side. So in order to have at least 1.5 millimeter thickness of the buccal and the palatal or buccal or lingual bond plate. So do remember 1.5 millimeter remaining in both plate. And after that, we can prolong the osteotome. We can split the ridge, or we can talk different way, is split the ridge farther from mesial and distal side, and then apply the magic expander into the proposed implant side, and then we wiggle the tune to gradually expand the anterior ridge. And also when we wiggle the magic expander inside the implant side here, we also create the condensing force to the cancellous bond also. So this kind of technique, this kind of BAB is a combination of ridge splitting and osteotome expansion. So this technique is very promising. It's combine the two advantage point of the two techniques. So this kind of technique is not only used for the IBS magic core system, but only for the whole implant design system in the market nowadays. So turn back to the previous case. So after I extract the uncompromised tooth from the number 32 to number 42, and we use the BAB technique to gradually expand the anterior ridge, and then place the two IBS magic coil inside. So that is the X-ray after we take after the implant placement. And then also, we don't wrap anything inside the extraction socket. So you can see the empty space in the extraction socket only extracted the teeth, and then do the excavation to remove the whole granulation tissue, and then place implant, and then make the temporary prosthesis. So the temporary prosthesis here is a no loading. It's just for the keeping the aesthetic for the patient. And then this the picture, intraoral picture after 1 week, when the day the patient came back to suture, to remove the suture. So the whole soft tissue is healing very good. So the extraction socket is disappeared. The primary healing is very well in this surgical site. And this is the picture after remount. So we make the final prosthesis for this case. And the patient, this is 1 year after the loading. So despite any bone grafting or soft tissue grafting, the bone remodeling process is appearing gradually in this X-ray. So we can see the cortical bone is forming in this area forming, and this area is adjacent to the big lesion here. So you can still see no cortical bone plate in this area, but soon, maybe after 1 year, the cortical bone plate will be formed at this area. So I found a video clip is regarding to performing of this technique. So let's look at the video clip here. So this video clip is the operation. The dentist want to perform the placement of implant at this area, at the lower posterior. First, he create osteotomy, and then use the magnet expander, malleting to advance deeper to the length of the implant, 2 millimeters longer than the proposing length of the implant. Then change the bigger expander to make it more bigger. Just wiggle the tune to compression the bone, condensation of the bone. And then because he plays the IBS magic chord, so he create the osteotomy for this implant. And after that, place the implant inside. And right after the implant placement, you can see the width of the ridge is expanding very much when we compare with the initial picture. Sorry. And then this final setting after 4 months after the healing. So this is the video clip on the VEB technique. But VEB technique is not only used for the bone expansion, it's also used for the sinus lifting. But first of all, I want to introduce for you first about the CMC technique used in the sinus lifting. So let's talk about the sinus lifting. So when we do the sinus lift in the implant treatment, have we ever faced with the implant floating in the sinus floor, like in this case? Or when we do the direct sinus lift or lateral approach, when we open the bony window and then we close the surgical site, but after a few days, the healing is not good, so the whole operation area is exposure. Or we can face with the wrapping material is floating inside the sinus. Or when we face, or have you ever faced with some pathology sign lesson like mucosal inside the sinus, or the very common complication is swelling after the sinus lifting. So those kind of complication is very easy phases when we do the sinus lifting. So let's look at the technique of the sinus lifting. So those picture is did by myself. This one is a lateral approach. I did this maybe 4 years ago, and this one is the CMC technique by Dr. Wang just recently. So in the left hand side is a direct sinus lifting. Why we call it direct, and then the right hand side indirect, and the reason why we call it indirect. So let's look at the below slide. So the direct method, or another name is a lateral approach for the sinus lifting, is original from the Caldwell Lock surgery from ENT, not come from the dental field, but come from the ENT field. And the first dentist who used this method to lift the membrane and place the implant is Dr. Hugh Tatum in 1975. So he calls direct because we can see direct the membrane, and the tool is direct touching the sinus membrane and lift it up. That's why we call direct, because everything is direct touch with the membrane. And the indirect methods is we create the surgical site on the osteotomy at the resto area here. So it have another name, is the resto approach. So this method is proposed first of all by Dr. Summer in 1986. So this picture is the picture here is an illustration for those kind of techniques. For direct method, we have to create a bony window in the buccal plate, and then direct lifting the sinus, place some bone substitute inside, and place implant. For the indirect methods, we only create a small hole in the resto area and use the tool to lift the sinus membrane off. So this indirect method is much more easier for the sinus lifting. But in the history, when we look at the literature, the recommend for those kind of methods is different. For the direct method, they recommend it we should use for the case that the subantral bone height less than 5 millimeters. But for the indirect method, we can use it when the thickness of the bone is more than 5 millimeters. But however, the direct method is a more invasive treatment. It have more complication, of course, because because the indication for this technique is much more difficult for the indirect method. And because the surgical site is very big, the operation view is very big, so the chance to get infection is much more higher than when we did the indirect method. And of course, it's very discomfortable for the patient post-surgery. But some they never do the indirect method. They always try to do the direct method, despite the subantral bone height is more than 5 millimeters. So this is one of the human being, because we want to control everything. We want to see the membrane directly, and we want to feel the membrane. So this is just a human being. But let's rethinking about the indirect method. Can we use it for the case that we have less than 5 millimeters of the bone thickness? Is a can we do it or not? So let's look at one of the main complications when we do the sinus lifting technique, both direct or indirect method, is membrane perforation. So this is the most common complication, and every 4 cases we have to face with 1 case of membrane perforation. So it's very easy to catch to face with the complication. So when we compare the complication rate, the perforation rate between the indirect method, I mean the Resorption approach, is much more less than the direct method. So, but anyway, when we facing with some case like we have the sinus septa inside the sinus here. So if we use the direct method, the subsequent time is increased much more higher than without sinus septa, because we have to create a 2 bony window, and when we lifting the sinus at this corner, it's very easy to get the membrane perforation, or this area. This corner is very easy to get the perforation of the membrane. Or when we face a mucosal, we cannot do the direct method. We have to transfer to the ENT doctor to remove the whole pathology, to remove the lesion out of the sinus, and waiting more than 1 year for the sinus healing, and then we can place implant. So when we facing this kind of patient, it takes a very long time waiting if we decide to go with direct method. When we checking on community, we observe that it have a PSAA, the artery, at the bony window we want to create. So if we don't notice in this artery, we create a bony window here, and then the bleeding is non-stop. So it will be we will be facing with another complication. This is a very common disease of the patient. But when we do the sinus lifting using the direct method, sometimes we forget to ask the patient about the habit of the patient. If the patient have the sniffing habit, sneezing and sniffing habit, when we do the direct method, it's very easy to get the complication with those kind of patients. So do remember, ask your patient detailedly about the habit of the patient regarding to the nose. And you should put it in your medical record when we facing with the sinus lifting. So let's look at the development of the indirect sinus lifting method. First reported in the literature in 1994, also by Dr. Summer, using the osteotome, of course, invented by him. And in 1999, Rosen proposed a little bit changing with the Summer. Instead of he left the lifting space nothing, he add more bone substitute inside the sinus area. This is the main difference between the Rosen and the Summer, is have or don't have the bone wrap, with or without bone wrap, that's all. But in 2003, Muronoi from Japan, he proposed the different technique. Instead of he used the kit, the osteotome, to lift the membrane, he used a balloon, because the balloon is more softer. It's more softer than the metal tip of the osteotome. So he think that the chain of tear down the sinus membrane is reduced. And 2005, Chen from Korea also invented using the water pressure to lift the membrane. But this kind of technique we'll be facing is we cannot control where the water is floating. Okay, we cannot control how much and how far the membrane is clipping up. And the most important thing is when we pour the water, when we push the water inside the lifting space, the whole blood and the bone fragment is flushing out. So the blood and the bone fragment is the mandatory key point to the bone regeneration in the future. So it has been proved in a different study. Is that the bone, when the bone is the bone regeneration is only happen is based on the blood clot and the bony fragment inside the sinus lifting area. So when we use this kind of technique, the whole thing is flushing out. Okay, and another technique is mainly used nowadays is using the denser burr developed by Huawei, and we have the term is Osteo Densification. It's used the burr to gradually compress the cancellous bone into the floor, the sinus floor, and lift it up. So those kind of technique, those kind of indirect technique, is only recommend when we want to lift the membrane, not more than 3 millimeter, not more than 3 millimeter. Because when we lift the membrane at more than 3 millimeter, the perforation could be happen. But recently, Dr. Wang is he's also invented the technique. Name is CMC. It's restore approach with the membrane control technique. So it's very brilliant idea. It's same with osteotom, invented by Dr. Summer, but have a lot of modification. So what is the modification of the technique? So when we compare the osteotom technique with the CMC technique invented by Dr. Wang, this is the my tune kit. When we use the osteotom, is a combine of a different diameter of the osteotom. Okay, but the CMC technique is used only once magic sinus lifter. So when we look at the end, the kit end of the tune, we can see the difference. In the left hand side is the magic sinus lifter. In the right hand side is the osteotom. So when we look at the end of the osteotom, we can see it's a flat surface here, and a small concave is very shallow concave of the tooth end to keep the bone inside here, and then to elevate the membrane. But when we look at the sinus lifter, we can see it's have a sharp end to cut the bone is more easier than using osteotom. And also, it have very big hollow inside the end to keeping the bone in place. So with this kind of geographic, okay, just a very shallow concave, so the bone fragment could be easily sipping out of the kit. But in this case, the bone fragment will be kept in place here, is never going out of the kit ending. Okay, and beside the sharp tip is also have the two blade facing the mesial and distal of the ridge. So which is the function of the ridge here, of the blade here? So when we do the malleting, so when we're knocking the sinus, with this tune, with the osteotom will moving and sitting inside the osteotomy. But when we're using this blade, the tune is fixed inside the sinus, inside the side, the implant side, without shifting the tune. So it's a very good modification of Dr. Wang. And so we keep the tune. It's not only easier for further experiment, but also keep the tune in place. Is no moving when we do the malleting. So this is the main difference between the two kinds of tune kit. So what is the principle of the two technique? So the principle of the two technique is we lift the membrane through the bone fragment here. So the principle is we never touching the membrane. Let the bone fragment lift the membrane out. This is the basic principle of the two techniques. But what is the reality when we're using those kind of techniques? So I did some experimental. I used the 10 model to see the difference when we're using those kind of technique. So when I use the Osteo tom, the bone fragment is broken into the two parts. But when I use the sinus lifter, magic sinus lifter, the bone fragment is only one part. And we take a closer look here. So please remember is we want to keep the bone fragment still intact with the tune, but with this kind of geometric, because the shallow concave here, so the bone fragment is very easy to flip out, to zip out of the tooth end. But with this bone fragment, we can see here, so the bone fragment is lying deep inside the hollow of the tooth ending. So with this technique, with the sinus lifter, the bone fragment is never going out of the kit of the tune, of the tune tip. So we can see the totally different. So when the bone fragment is zipping out of the tune kit, the Osteo tom will directly touching the membrane, and it could create the perforation for the membrane. So this is the reason why they recommend using this kind of technique only for the case we want to lift 3 millimeter of the sinus floor. Okay. So when we compare, when we measure the square of the bone fragment, so the minimum square of the bone fragment is 7 millimeters square. So please do remember the number of the square of the bone fragment is 7 millimeter. So I will explain it in the next few slides. In the next few slides. So I would like to call the sorry. Can you turn off the annotation on my screen?
Give me a second.
Okay.
How do we do this?
Click on the annotate and eraser. You click on the annotate and choose the eraser. Okay. I will stop my sharing and then reshare again.
Okay.
Okay. Wait a minute. Okay. Okay, turn back to my presentation. Okay. So I would like to call the sinus membrane or Schneiderian membrane is the Hercules. So why I call it Hercules? So like all of us know, Hercules is a very powerful man. He's very strong man, and he had a lot of ability, right? So let's look at the mechanical property or the strength of Schneiderian. So I found two particles is introduced is published by Palmer and from China. So why the two publications here? The reason because they did the experimental on both Caucasian and Asian ethnic. So both Caucasian and Asian ethnic, they share the same mechanical property of Schneiderian membrane or the sinus membrane. So the critical perforation force, it means the force required to make the perforation of the sinus membrane is 7.3 Newton per millimeter square. And the force that stick the membrane into the sinus floor so is 0.05 Newton per millimeter square. And the membrane could be stretched more than 125% in 2 dimensions, okay? Sorry. So what does it mean? And through this kind of number, can we predict the elevation force, and even can we predict can we make the perforation for the membrane or not? So let's do some mathematical. So just assume that I want to elevate the membrane 9 millimeter, okay? So using the Pythagoras formulation, okay, so I can count the square, the adhesion square of the membrane to the sinus floor is 453 millimeters square. So to lift the membrane up to 9 millimeter, okay, I need to detect the membrane in the area have the square that 453 millimeters square. So based on the previous research, I could count that the elevation force need to detect the sinus out of the bone is 22 Newton. But the bone fragment before that I showed you is the minimum. The minimum square of the bone fragment is 7 millimeters square. So when we compare the force to let the bone fragments, to let the 7 millimeter square bone fragment to get the perforation on the membrane, so the force have to be more than 50 Newton. So the gap between the 22 and 50 is very big. So when we well manipulated and the force is enough to elevate the sinus floor, the Schneiderian membrane, there will be no perforation for the membrane, even when we want to lift into 9 millimeter, okay? So beside the membrane is very strong, the strength of membrane is very good, that I showed you to the previous formulation. The Schneiderian membrane is a reservoir of progenitor cell. So the progenitor cell is the cell needed for the formulation of the bone and also the soft tissue also. But the sinus membrane is also a periosteum, and it's comprised of a lot of mesenchymal stem cell, and it have osteoblast. Its main function is to create a bone, and the periosteum or osteoblast or mesenchymal stem cell is play a major role in the vascularization and bone formation. It was proved many years ago, not recently. So from the scientific side of view, we know that the periosteum or the sinus membrane plays a very critical point, very critical role in bone formation. And especially the periosteum derived cell, it means the cell come from the periosteum. It have a very good regenerative effect. So it could shorten the healing period when we do the sinus lifting. So from the previous research, we know that the CMC method is a very predictable method. It's very easy to apply because we only need to control the melting rate and then the velocity of advancement. That's all. So it means that we need to have the well training of this kind of technique. And from that point, every case will be safe. So this is the basic protocol of the CMC technique. It's same with the osteotom invented by Dr. Summer from 1994. We had to leave the sinus floor as a maximum at 2 millimeter. Is the remaining bone here 2 millimeter, and then we use the sinus lifter malleting to break the sinus bone, the sinus floor bone, and then the sinus bone will advance into the length we want to place the implant. Okay, not only 3 millimeter, but you can advance the membrane up to 9 millimeter without perforation. Beside the basic protocol for the lifting the sinus, the IBS company have invented the protocol using for the inclined sinus floor. So it's very brilliant idea here. So when I facing with the case like this one, this is the case this just 2 weeks ago. So when I face with the case like this one, have a sinus septa inside the area I want to place implant. Instead of I have to open a 2 bony window and took a lot of time to elevate the whole membrane out of the sinus floor and placing implant. So the whole procedure before 2 years ago when I facing with those kind of treatment, it cost me more than 40 minutes to finish the procedure. But now with the CMC technique, by using only one hole here, you can see the hole here, only one hole, and lift the membrane and place the implant without perforation of the membrane. Okay, this is a picture of this case. Not only proved by the mathematical, this kind of technique will have the experimental conducted by Dr. Wang in French. He did experiment in 45 fresh cadaver study, and using the sinus lifting CMC technique to lift 8 millimeter of the sinus membrane, and the result is no case of perforation. So this was publication in 2019 in a GOIMI journal. So by using this kind of technique, I can conduct a lot of numerous cases of sinus lifting without perforate the membrane. Not only using the IBS magical system, but also you can see here I use Nobel Biocare and Strongman and Dentium and a lot of brand. Every implant system can be used with this brilliant technique invented by Dr. Wang. Like I mentioned before, some earlier slide before that, BB technique used for bone expansion could be used for the sinus lifting also. So when we're facing with the case that the remaining subantral bone height is more than 5 millimeter, instead of using very dedicated to magic lifter, it's very easy to bending the end of the sinus lifter. We can use the magic expander. It's more rigid. It's more stronger. It's more harder than the sinus lifter to lift the membrane up to 3 millimeter. So this technique, BAB technique, when using for sinus lifting, the limitation is only 3 millimeter. Okay. So the minimally invasive treatment, of course, we cannot open the flap very big, make a big bony window, split the bone is very wide, and play a lot of bone inside. Never come with those kind of treatment. Those kind of treatment is I did before in my clinical workflow. When I before I attended the class in Korea in last year. So minimally invasive treatment never come with those kind of procedure. So let's look at some case. First of all, is the case did in Korea by Dr. Min to see the procedure of the CMC technique. So in this case, the operator, the doctor, is also did two kind of technique, BEB technique for tooth number 16 and CMC technique for tooth number 17. Okay. The first step is he wants to create a tissue punch. He wants to cut the soft tissue out of the implant side. And the second step is he wants to create osteotomy 2 millimeters far apart from the sinus floor. And then at the tooth number 16, he used the magic expander or the BEB technique to elevate the sinus floor off. And in the tooth number 17, he used the sinus lifter using the CMC technique to lift the sinus floor. And place some bone particle inside the lifting area, and then place the implant. So the whole procedure for those kind of technique is very fast. The total operation time is only under 30 minutes for the two implant sides. X-ray after the surgery, and then this is the final setting after 3 months. So let's move on another cases. So the patient presented to me that he want to do the implant treatment in the upper left area, posterior area. So I decided to play the two implant with the CMC technique for the both area. So when the remaining thickness subantral bone height is only 3 millimeters, using the CMC technique and then place the implant. So this is right after the implant placement. There's the X-ray checking the placement of the implant. And there's various X-ray to see the formation of the bone around the implant. So after 10 months, we can readily observe the formation of the cortical plate inside the sinus floor. It means that the bone is regeneration around the implant. This is the final picture, intraoral picture. And another case is also when the subantral bone is less than 2 millimeters, that we're using the CMC technique and then place the implant inside. And then just few months later, 4 months later, loading the implant. And this is the 8 months after the implant placement. We still observe the formation of the cortical bone plate in the sinus floor. It's proof that the bone formation around the implant and the implant is well functional, okay, in this kind of treatment. There's a community to check the formation of the cortical bone plate here and here. And another case is just recently, the patient with the compromised endodontic tooth in the position 2-7, I have to extraction, do some excavation, and the remaining technical bone is only 1.3 millimeter. So it's an immediately placement in this this patient. And then after the placement, extraction and placement. So I can show you the clip. Is this case I do and don't place any bone wrap material inside. And then now you can observe the stability of the IVS muscle coil in the implant side with only 1 millimeter engaged to the implant. Okay. So you can see here when I use a forceps to wiggle, to moving the implant, but the implant doesn't move, didn't move. The whole head of the patient is moving. So it proves that the stability is not good in this case. So this is X-ray, the community X-ray taking only 1 week after the implant placement. This X-ray after 1 month without any bone wrapping, no suturing, no, I mean the primary closure, no primary closure, no bone wrapping, but the bone is formation gradually, and even the soft tissue healing gradually. So this intraoral picture after 1 week, still see a very big gap here. So because I don't do the primary closure here, it's only after 1 month. And now observe what we have after 2 months. The bone formation is right at the junction between the rock surface with the magic cup here, without any wrapping material and primary healing and primary closure. And this is a picture after the 2 months. And because of a corona, the COVID-19, so I cannot place the prosthesis for this patient. So maybe if we can remit again in the next few months, I will present to you some more case regarding to those kind of technique. And thank you for your listening and for your kindly attention on my speaking. And also, if you have any question, just let me know, and then I will try to answer it.
Thank you, Dr. Ando. Actually, yes, we do have questions. I just took out 4 questions out of the chat. So here they are. The first question, how to achieve expansion in maxillary anterior region? So in the front region.
Yeah, of course. For the maxillary is more easier when I presented to you the first case, right? The mandibular bone is more difficult because the cortical bone is more thicker when compared with the maxillary. So we just apply the same principle of the BAB technique, and then we can expand the ridge and angular ridge in the maxillary. It's much more easier when we did in the mandibular. So use the same principle and the same technique with the case I presented to you, the first case.
Thank you. So the second question, it's kind of interesting one. What is the rate of bone resorption of BAB technique compared to previous techniques, ridge splitting, osteotome technique, and by using piezo? Here, okay. I think it's more like connected with the bone densation.
Yeah, it's very interesting question. So the rate of bone resorption, of course, I did no research regarding to those kind of technique, but do remember why we have the bone resorption. First of all, the bone resorption is because of we don't have enough of the blood supply, right? So the blood supply is for the umbilical bone is come from the 2 parts. I mean only for the edentulous space, come from the 2 areas. The first one is inside the canceller area, inside the canceller bone, and the second source is from the periosteum. So when we use just logical thinking, that when we create the split, we have to open the flap, right? We have to open the flap. So we cut the sore, we cut the blood supply from the periosteum. And then when compared with the BEB tech, because it's a flapless surgery, so the supply, the blood supply is come from the two source. So the bone resorption rate, I could tell, is based on my my thinking, my opinion, is lesser than with the ridge splitting. That's why some of the other, when they propose with the ridge splitting, they always recommend do the bone wrapping between the two plates. But BB, we don't need that.
Thank you. And the next question is also from Dr. Suresh from Nepal. Can we perform sinus lifting procedure in chronic sinusitis cases? So I think there is like more pressure on the membrane and there are more chances of tearing it. So how to overcome this kind of complication?
Okay. So for the chronic sinusitis, I don't recommend to do the sinus lifting. Yeah, because when the patient have the sinusitis, the membrane is more easier to be teared down. So even when we do the lateral approach, the perforation occasion is much more higher. So I just recommend just transfer him to the ENT doctor to do to treat the sinusitis, or we can open the, or we can use the lateral approach. Don't use the indirect, because when we use the indirect technique, we cannot observe the perforation of the sinus membrane.
So so we have to heal sinusitis and then perform the operation.
Or we can do the lateral approach, open the bony window, and then if any perforation happen, we can treat that also.
One more question. I think there will be like two more after that. They're quite easy. What's the benefits of using magic cord together with CMC technique? So can we perform CMC technique and place another implants, or is it compulsory to use magic cord?
So because the red design of the magic cord is thinner than the other thread of the implant system. So when we face with the clinical situation that we have only 1 millimeter of the bone for the implant engage, so engage inside the bony part, right? So if we use the IBS magic cord, we have more chance to get the initial stability when we use the different implant design. But with the remaining bone more than 3 millimeter, the difference is not much. Okay, so the IBS magic cord can be used for the extremely case when the bone is less than 1 millimeter. Okay, this is the main difference. I think this is the main difference because the design of the implant thread.
Thank you. The question from Bangladesh, I think, how to match the thread according to drill precisely. If the drill and implant thread does not match, isn't it possible to damage interthread bone?
Okay, so let's turn back to, because I don't have chance to introduce for you more detailing about the implant thread of the IBS magic cord, but based on the previous lecture by Dr. Chumpon, we know that the thread of the IBS magic cord is a square thread. The first one is square thread. The second thing is a very deep thread, and a third one is a very thin thread, only 0.15 millimeter. So this kind of thread design is have a very good function. Is we call is cell tapping. So when we use the IBS magic cord in the case like bone D3 or D4, we don't need to use the tap reel. We can use the implant to reel inside the sinus because the thread can cut the bone itself. So when we're facing with the case like the last case I presented to you, that I don't use any tap reel or don't use any kind of the reel. Only elevate the membrane and then place an implant inside the hole I created by the magic sinus lifter. Because I knew that the thread design could be used for create the tapping inside the bone. Okay.
We're almost out of time. Another like really quick question. In your presentation, in your surgery, the bridge, what size of implant did you use?
Depend on the size. Okay, for the thing for the first case, I use the diameter is 4 millimeter. But for the posterior area, I mainly use 5.5 millimeter.
Okay.
The diameter. Okay, the length is based on the prosthesis, so I can decide the length. But the diameter is mainly 5.5 for posterior and 4.0 for anterior.
Okay, thank you very much. As of now, we're really run out of time. We're quite delayed in our presentation. We have lots of questions still coming, and lots of questions from Bangladesh, from Nepal. I'll leave our contact information so that all the questions can be received. Please thank you, Dr. An, for your great presentation. Hopefully, we'll have another one in near future so that we'll have more time for more detailed explanation on the techniques, on the characteristics of the implant. And we really appreciate your time.
No, thank you. Thank you.
Thank you very much.
Thank you, everybody, for your time for listening to my presenter.
Thank you. And everyone, I left our contact information in the chat session. So please make sure to send your contact information back to us so that we can get in touch with you. There's also links to our Facebook and YouTube page. Make sure to subscribe. There are a lot of technical videos, a lot of surgical protocols you can watch and implement. And make sure to leave your contact information so we can invite you for on and off seminars in near future.
Bye.
Thank you very much, Dr.
Thank you. Goodbye.
Goodbye. Yes, and all the questions you can leave either here in our chat session or send it by email to the info@ibsimplant.com. Me personally, I'll be checking it. So I'll be the one who will respond here. Thank you very much, everyone, for your time shared with us, and have a great evening.